Let's understand the anatomy of pleura. Pleura has two layers. First, the visceral pleura, which is adherent to lung except at pulmonary ligament and hilum. Now, let's understand the anatomy of parietal pleura. Parietal pleura has four parts: the costal part with the ribs, diaphragmatic parts attached with the diaphragm, mediastinal part, that is towards the mediastinum, and the cervical part. Now, let's understand the surface marking of parietal pleura. If we start from the sternoclavicular joint, then we can move towards medial 1/3, and the medial 1/3 mark a curved line from sternoclavicular joint to the junction of medial 1/3 and middle 1/3 of clavicle, 2.5 cm above the medial 1/3 of clavicle. Rear margin, there is a difference between right and left side. On right side, the line from right sternoclavicular joint extend to midpoint of sternal angle. Then it further extend to xiphisternal joint. But on left side, this line extends from left sternoclavicular joint to midpoint of the sternal angle as in the right side, descend vertically up to the fourth costal cartilage, from where it arcs towards the sixth costal cartilage. This is basically to represent the deviation that is due to the location of the heart. Now, for the inferior margin, the line extending from the xiphisternal joint on the right side crosses 8th rib in mid-clavicular line, crosses 10th rib in mid-axillary line, and for 12th rib in paravertebral line. But on left side, the line extend laterally from left 6th costal cartilage and follow the same course as on the right. If we look for the posterior margin, then the line extend as a vertical line 2 cm lateral to the spinous process of vertebra C7 to T12 vertebra. In part 2 of anatomy of pleura, we will understand the recesses of pleura as well as the clinical significance of pleura.
The recesses of pleura are hard to understand, so let's understand in an easy way. There are two recesses of parietal pleura which act as reserve spaces for the lung to expand during deep inspiration. First one is costomediastinal recess, which lies anteriorly behind the sternum and costal cartilages between the costal and mediastinal pleurae, particularly in relation to the cardiac notch of the left lung. This recess is filled up by the anterior margin of the lungs even during quiet breathing. It is only obvious in the region of the cardiac notch of the lung. Second one is costodiaphragmatic or costovertebral recess, which lies inferiorly between the costal and diaphragmatic pleurae. It extends from the 8th to 10th ribs along the mid-axillary line. During inspiration, the lungs expand into these recesses. So these recesses are obvious only in expiration and not in deep inspiration. Let's understand clinical anatomy of pleura. First one is paracentesis thoracis, which is aspiration of any fluid from the pleural cavity. It is usually done in the 8th intercostal space in the mid-axillary line. Next is pleurisy, which is inflammation of the pleura. Moving on next to pneumothorax, that is presence of air in the pleural cavity. In place of air, if there is blood, then it's called hemothorax, and if both, then pneumohemothorax. Presence of pus in pleural cavity is called empyema.
Let's learn to recognize some classic findings that every healthcare student should know. Pleural effusion, paracentesis thoracis. Imagine fluid slowly accumulating around the lung. The earliest radiological clue is often the loss of the sharp costophrenic angle, known as CP angle blunting. As more fluid collects, a graceful curved upper border appears, the famous meniscus sign. In larger effusions, surrounding structures become obscured, producing the silhouette sign. After paracentesis thoracis, the fluid decreases, the costophrenic angle reappears, and the lung gradually re-expands. Pneumothorax. Now, imagine air entering the pleural cavity. Air where it doesn't belong. The key finding is a visible pleural line. Beyond this line, lung markings suddenly disappear. This absence of markings indicates collapse of the affected lung. Hemothorax. In hemothorax, blood accumulates within the pleural cavity. Radiologically, it often resembles a pleural effusion. You'll see a homogeneous pleural opacity, along with blunting of the costophrenic angle. In such cases, clinical history becomes essential for diagnosis. When air and blood are present together, the picture becomes much more distinctive. Look for a sharp horizontal air fluid level. Air above, blood below. This finding is highly suggestive of hemopneumothorax. And that's how radiology helps us visualize pleural disorders. From fluid and inflammation to air, blood, and infection, each condition leaves behind its own unique radiological signature. Keep observing, keep correlating, and keep learning with Vedvriti Academia. See you in the next lesson. Bye, stars!